Welcome to our Talking Women's Health podcast. This is where we get to have amazing conversations with fabulous leaders in OB-GYN. I'm Dr. Amy Young. I'm the Executive Director of ABOG, and today I'm here with my guest, Dr. Ronald Alvarez. Dr. Alvarez, as we know him as Ronnie, and he is the Betty and Lonnie S. Burnett Endowed Chair of Obstetrics and Gynecology. We're so glad that he's here with us today. Ronnie is an amazing leader in obstetrics and gynecology. He has served many leadership roles and has been a major mover and shaker in the field. He served as the president for the Society of Gynecologic Oncology in 2013, and he is the immediate past president of the American Gynecologic and Obstetrical Society, serving in that presidential role in 2024. So he's just shifted into sort of the past president role. He currently works with me very closely at the board as he's our treasurer, and so I'm so glad that he's here with us at ABOG. And I have to say personally, he's been so helpful to me in sort of the transition in my executive director role, and I've learned so much from you, Ronnie, over the last year. He also chairs the NRG Oncology Research Strategy Committee, and he's the chair of the OCRA Scientific Advisory Committee. So you wear so many amazing leadership hats for our field and for GYN oncology.
Well, you're too kind. I've just have had great opportunities to serve in many different capacities. I like to say I'm really great at nothing, but I'm good at a lot of things.
Well, that's fantastic. You know, your leadership, besides the fact that it has been really amazing from my vantage point in really getting to know you over the last 18 months. It's not that you lead and you maintain. You're sort of a driving force in pushing things forward, evolving, innovating. I think really painting a pretty clear vision of where the future is and getting people sort of aligned behind what that is. So I just wanted to know if you would share a few of your tips and tricks with this group. You know, hopefully we have a lot of future leaders in our listening group or in the folks that are watching us. And tell us about some of those tips and tricks that you've encountered.
Well, first of all, I've learned a lot from you over the past 18 months, and it's been a real pleasure to work with you in your new capacity as the Executive Director of ABOG. I think there's a couple of things that I tell or try to teach some of the junior people that I work with and trainees. I think I have this, what I call the 98% rule, is 98% of success is just showing up, working hard, being nice to people, and taking advantage of the many opportunities they may have to contribute to the field. The other thing that I am a firm believer in is that the only permanent thing is change. Mm-hmm. And so our specialties, our field, women's health, is constantly changing, and we as leaders in the field and leading organizations have to be on the forefront and looking to see where that puck is going. So I'm been a real believer in the fact that change is inevitable, and we have to continue to adapt to the things that are happening around us that most impact women and their health. And I'm singularly focused on the fact that we have a great purpose in serving the women of this country and the women internationally.
You know, one of the things that I think about leadership is that it takes courage. You know, doors open and some people walk through them and some people don't. Once you walk through them, you kind of have to do the work and do the job. How do you sort of think about what are these leadership roles that you're going to take on? Do you look at them all the same, or do you just see the opportunity there and sort of just go for it?
I think one of the things that I try to encourage younger people to do is, or to think about is, it's easy to stay within your comfort zone, right? What am I comfortable with for clinical medicine or education? But if you're going to grow, you really need to get out of that comfort zone. It's the place where you'll experience the most growth. And people will say, I don't know how to do that, or I'm not experienced, or I'm not, perfect enough at it. Well, to avoid the perfect, you don't do anything. That's not really good. So just trying to get some experience, and there's a great saying that says every expert was a beginner at one time. So just get involved and learn more about it, and sooner or later you evolve into somebody who's really contributing in a particular area. You can follow what your passions are, and if you're interested in in administrative work or clinical quality work or education or research, just follow your passions. And it tends not to be a job. It tends to be just you doing your work that you love to do.
You know, I have a relationship with a personal coach that I've had for a long time. And it's actually one of the most valuable relationships that I've ever had. And, you know, everybody suffers from imposter syndrome. So I think people sometimes don't take a role that they have where they have the ability to contribute just because they're sort of afraid. And so your words about getting comfortable with being uncomfortable, I'm going to rephrase what you said.
Right.
I think are sort of important because, you know, one of our tenets here at the board is about the promotion of mastery, right? We should continue as OB-GYNs in order to provide safe cares to push ourselves sort of to that level of being a little bit uncomfortable because otherwise we become complacent and we sort of lose that skill and ability. I think what you said is so important about being comfortable with being uncomfortable because if we can't sort of adopt that mantra overall, none of us are actually going to reach mastery and really promote the best care we can for the patients that we have the responsibility of caring for.
I think I didn't go and interview for a position in OB-GYN residency thinking that I was going to be the chair of OB-GYN at Vanderbilt or the president of AGOS. Just got finished with a huge year of imposter syndrome. But I would say that we all have potential that we don't think we have, right? One of my favorite sayings to resident applicants is that my job is to get the potential out of you that you don't think you have, because people levered into me and helped me reach heights that I didn't think I was ever going to reach. I never thought I would be a chair of a department of OB-GYN, much less the president of AGOS.
Well, let's talk about AGOS a little bit. You know, there's all these Ogs and Goes in OB-GYN and understanding all of these societies and where they came from and their history and what they really mean is pretty confusing. And I think it would help our listeners a lot to really understand what AGOS is, what's its purpose, its mission, and then could you tell us a little bit about your role and what that last year has been like?
Oh, I'm happy to do that. AGOS is an incredible organization that most people don't really know about. It was the first organization for OB-GYNs long before we had any other organizations, long before we had the board, long before we had ACOG. And so they were really the leaders in our specialty and subspecialties before we even had subspecialties, to be frank. They were leaders in OB-GYN and women's health that would get together. And this started in the 1800s. It started with two organizations that ultimately merged in the early 80s to form AGOS. And they actually consist of leaders, academically accomplished people, but otherwise leaders in the field that keep pushing the envelope on how we deliver women's health, who have the opportunity to work collaboratively together amongst all specialties and subspecialties to sort of see where we stand with women's health, what are the key issues that need to be addressed, and how can we, as a group and organization, work with many other partners to be able to move the needle where we need to in women's health.
So last year, it was a big lift. I think it was a lot of work
being
the president. I'm sure it's a huge honor that it was a lot of work. What was that year like for you? How did you did you vision for the year and what you wanted to get accomplished ahead of time, or how did that work?
Well, it was a great privilege to be the president of AGOS, and I would say that over the past decade, we've had a series of presidents who have worked to sort of re-engineer AGOS, and so it's been a number of different things that have been accomplished over the past several years, not just in my year, but I had the distinct privilege of being able to create a new strategic plan for the organization. The last one was in 2018. It was time for a new one. We actually changed the bylaws. We created a lot of new policies. We're trying to actually move AGOS from being what has been traditionally thought of as an honorific society to more of an action-oriented society that can address the major issues that are ongoing in women's health and in our specialty, and to create creative ways to work with a lot of stakeholders to be able to move the needle and make some of the changes we need to make to address those major issues a little bit. I think, in my opinion, the AGOS can function much like the National Academy of Medicine, but be specific for OB-GYN.
You know, I had the opportunity to go last year. You invited me, or I think Warner invited me, and so, you know, it was a really good experience. I had never gone to AGOS before, and so just getting to see the specialty where everybody wasn't sort of in their silo. So I wasn't a generalist or a specialist, and you weren't a GYN oncologist. You were an AGOS member, and so there was I got this feeling of this shared common purpose that we were all trying to accomplish to move a bar to go one direction, but it was really where people sort of left their subspecialty or non-subspecialty status sort of at the door, and just I think everybody was really focused on what was important to move the specialty forward.
Well, first of all, we're so happy that you're a new member of AGOS, and congratulations on that, well deserved. And we need your leadership in this organization for sure. And I think, you know, the great thing about OB-GYN is that we've been able to sort of differentiate into more and more specialty, a subspecialty, and even sub-subspecialty a little bit. But this is really the one place where, and like you said, those subspecialties or specialties end up being, you know, siloed into their area of interest, which is great because that's where a lot of great science is presented and advances are made in those specific areas. But this is the one area where we can have representation from all of those fields, get together and work collaboratively, again, to kind of address the major issues that we understand are happening in women's health and OB-GYN.
So one of the issues in the invitation I had last year was to participate in a panel. You know, there's been concern for more than a decade around surgical training in our field. And I've recently been asked to do a talk, and so I really have a good view of that actually across many specialties. It's a problem in all surgical specialties right now. So there's sort of a House of Medicine-wide concern for surgical training. I think that it is a sort of a multifaceted problem. The session that I participated in at AGOS was really focused on surgical training and, you know, concerns that we have for our particular specialty. And I know that this is something that's sort of near and dear to you. So can you help educate our listeners about some of your concerns around surgical education and, you know, why you put the panel together and what you hoped people would take away from that?
Well, first of all, it was great to have you participate on that panel because this is, like you said, this is not a singular organization problem to solve. It takes multiple stakeholders to address the issue. I think, you know, surgery in OB-GYN has changed, right? We have seen a decrease in the number of hysterectomies, which is good because now we have a number of non-hysterectomy options to treat patients for the conditions that they suffer from. We've moved from two types of surgery, abdominal hysterectomy or vaginal hysterectomy, to more minimally invasive surgical options, so that most of the hysterectomies that are done, even for cancer cases, are now done with minimally invasive surgical techniques. And so the modern GYN surgeon has less hysterectomies that they're doing during their residency, and they're also doing different types of hysterectomies, and majority of which are now for minimally invasive surgery. And the ones that we actually do open cases for tend to be more complicated cases that need the expertise of more advanced pelvic surgeons. But I think that there's not, in spite of these sort of advances, which have been great for women, there is an opportunity to think about how we actually train our residents and fellows to be to master, to speak to the term that you like to use, to master the surgical procedures that they need to do for the women that they will be serving.
You know, it's kind of interesting. When I finished, I think we're sort of the same genre. That's the way I like to say it. But when I finished training, you know, I was competent to do abdominal hysterectomy and vaginal hysterectomy. I remember sort of finding the very first laparoscopic assisted vaginal hysterectomy that was really ever done in our institution. I was a second-year resident. I knew I was not going to do it, but this patient sort of met all the criteria, and we got this case established. But, one of the things about mastery is, of course, I had to learn new techniques, right? I had to
Right.
learn to do a laparoscopic assisted vaginal hysterectomy and then laparoscopic hysterectomy and the robotic cases and all of that. So I think there's this thing for our learners that somehow they think they're supposed to know everything when they finish training, but you continue to learn throughout your life. And it's sort of, I don't know how we can make sure that our learners understand that they're going to have to continue to grow and develop throughout their careers.
Oh, absolutely. I mean, I think of residency as just the end of the beginning, right? And then you have a whole different career. For me, I hate to say that I'm old enough that we didn't have video laparoscopy when I trained, and we didn't have the internet or cell phones, to be frank. So, but just to tell you how old I am, but
I remember those days.
but I think I now am a very competent robotic surgeon and laparoscopic surgeon. So, to your point, and to the point I said earlier, there's constant change, and you have to continue to kind of learn how to use the tools that are evolving to be able to help your patients. But I think one of the things that I think is really important is even in the current environment where we may be having less hysterectomy cases or other surgical cases, it doesn't mean that we can't teach some sound fundamental surgical principles and that have to deal with how do we get a patient ready before surgery, what do we do during surgery, what do we do after surgery. And so I think there's many different steps in those three domains where we can actually have our trainees focus on what is the fund of knowledge that I need to have, how do I apply that? Again, I tell my residents a lot of times, my goal is to teach you fund of knowledge, skill sets, and the judgment to apply it, which I think is really important. We do that in the preoperative stage. In the operative stage, I think it's really important for us to understand lots of different things. Surgical anatomy is a key thing, using the equipment that we have, principles of how we dissect the tissue, the simple stuff like clamp, cut, tie, and those are the things that if we have some of those sound principles embedded into our trainees, they'll be able to apply them in any situation that they encounter after their training.
You said the word simple, and that resonates with me. One of the things I tell residents when I operate with them is don't make something simple complicated.
Right.
Because the reality is a hysterectomy, I don't want to oversimplify it for some of our listeners, but it's 4 blood supplies, right?
Right.
And then there's 4 big things to worry about. So worry about the things you need to worry about and go get the blood supply and, restore normal anatomy if it's distorted, and just don't make something complicated that's relatively simple. I say that because I'm not a cancer surgeon, right? But
well, I'd say the same thing. Our job is to make a hard case look easy. Mm-hmm. It's not to make an easy case look hard.
Right, exactly.
So I'm a firm believer in that.
Exactly. There's some other things about surgical education that, I think we have to kind of rethink about the future. And we are at the board, and it's in our strategic plan, sort of embarking on competency-based medical education. Or, so we're no longer going to rely on how many of something that somebody does, but when are they actually competent to do it with minimal supervision? And one of the things I've thought a lot about lately is, and how do we give them that autonomy in their training that seems to have been lost and might be one of these factors that affect competence? You had sent something, or you had shared something with me, so with our listeners, of course. Ronnie and I talked a little bit before we got together to do this podcast, and he's put together a pretty amazing, program there at Vanderbilt. Do you want to tell our listeners a little bit about your surgical program at Vanderbilt?
Yeah, I think it's again, as we discussed in our panel and as a paper that we've worked on a little bit, is making, being intentional about surgical training, right? Particularly since we have decreased volumes and we have, more trainees that we have to train. And I think that what we did was just to put this on paper and apply some of the principles that I've talked about previously. Instead of making A lot of surgical training is opportunistic, right? So like the resident who's on the service comes and does the case, and there's not much, thought into what does that resident have to get from this case and learn what sort of surgical procedures do they need to master and be competent in. And so we just put together a program that says when you're a first-year resident, you're going to learn to do these procedures and go through the same principles that we talked about, where you have a fund of knowledge about the procedure, that you're doing it on low fidelity, and if we have capabilities, high fidelity simulation models, and then you'll do it in real time, and you're getting a lot of feedback about your competency in doing that procedure, and maybe some more areas where you need to improve in the execution of that procedure. And then we graduate that up through the residency for what we want the second year, third year, and fourth year to master during their time of training.
So I have a hard question for you.
Yeah.
So I think one of the hardest things to do when you're teaching surgery is to be able to back off and let residents, as long as they're operating safely, let them sort of go and not be directive, because as long as they're doing it correctly, even if it's not exactly the way you would do it, just to let them go. So that's a hard thing for me personally. Do you find that challenging?
I do, and we have to use the judgment, right, to see what the nature of the case is. So if you have a second-year resident, but you're dealing with a case that really needs to be a third-year or more advanced resident or fellow, then we have to have that judgment to say when that this is beyond the skill sets of that particular individual for that time. But on the other hand, I think I'm like you. I've always been. The end is more important to me than the means, and sometimes if I letting residents or fellows proceed with things and they do it a little different than me, I have to sort of that's okay. And I may interject and say, when I have this situation, this is what I do. It doesn't mean you have to do it that way, but we do have to, I think if we're being intentional about surgical training and residents have gone through these, preoperative steps, then they'll be better prepared to know what to do and be more comfortable with the autonomy that we want to be able to give them. So
I'm going to shift gears for just a little minute. So one of the things that I talked about that day with AGOS is about our workforce. We have some amazing data from the board that we basically obtained it so that we could help personalize our continuing certification process and improve our individual diplomates' road to mastery. But it turns out we ended up with a huge amount of really important data for the specialty. So what are people actually doing in practice? Where are they actually doing it? And so one of the things I showed there is that we have really a maldistribution of doctors. We know from some other questions we've asked at the board that 80% of our folks want to go into urban areas. One of the primary motivating factors is they want access to subspecialists. I think, again, this is a big problem. It's a multifaceted problem. Any thoughts that you might have about how to begin to start to address sort of the maldistribution of OB-GYNs and women health providers across the country?
Well, ideally, if you had the chance, you would wipe it all out and design it specifically for what the population health needs. So we always have this sort of tension between how do we provide care to the population versus how do we advance the science of what we're doing, and the desire for people where they want to live and where they can, and the work-life balance issues that are really challenging in OB-GYN, right? OB-GYNs used to be smaller practices, work in smaller communities, be on call every other night. We just can't do that like we did before. So we can certainly work on health policy things from the federal government and state governments to entice people to kind of work in more, maybe less urban areas. But we also have to be creative and innovative and sort of think about, how we utilize other resources to help us provide women's care. So like in Tennessee, and I'm sure in Texas, we have about a third of the counties don't have maternal fetal care, or OB-GYN care. And many OB units have shut down. But so we may not have OB-GYN doctors in there, but I bet you we have retail pharmacies in all those areas where we can maybe engage some nurse practitioners or use some other creative ways to to be able to provide some healthcare and access to the system, and figure out how we can get people to get the care locally where they live, and it may involve some travel if they need to get more intensive care like delivery or surgical procedure, but we just need to be able to reach out to more people, and it concerns me that in some areas, both urban and rural, that there are women that don't have access to women's health care.
You have to have competent providers, right? And so that requires, use a phrase you said before about, surgery in some respects, surgical training is a bit opportunistic, right? Well, the reality is you can't train if you don't have enough density of experiences, right? And so that one problem that we have kind of begets another problem. But I do think it's sort of incumbent on us as leaders in the field to put our heads together and think about some of these innovative ways that you brought up. Maybe you use your retail pharmacy as your front door, but then figure out some sort of regionalization of care, I think is what you're saying.
Yeah, I'll also point out, if we want to talk about surgical care, so many people in OB-GYN who want to become better surgeons actually go into surgical subspecialty training, right? Minimally invasive surgery, urogynecology, GYN oncology. What's missing, the one big piece that's missing, is a more program type of surgical training for the OB-GYN resident who wants to go out into the community and be just a general OB-GYN. I'm going to say just, we're very thankful to have a lot of people that are OB-GYN physicians. And I think what, one of the things that I've thought about is to think about how in the first couple of years do we have like a pseudo fellowship for the general OB-GYN physician who wants to go out and become and master some surgical procedures. Maybe not all of them, but I want to be really good at these, several surgical procedures. And how can that person, do we provide from an organizational standpoint, here's a structured way to do that. Additional learning, additional surgical techniques, maybe even simulation, and working with, partners in their hospital. Obviously their OB-GYN partners, but even their general surgeons or urologists to just get some additional surgical experience. And I think that investment over a couple of years, like fellows do, and the other surgical subspecialties, would be of enormous value to them to be able to continue to grow their skills beyond the time that they're in residency. Yeah,
that sounds great. That sounds like something that we need to talk about further.
Yeah, no, the only thing I mentioned this because I saw my son do this when he's an OB-GYN, general OB-GYN practitioner, and in his first couple of years he operated a lot with his partners, and he's a pretty competent surgeon. I don't know where he got that from, but mainly from his training. So
I don't think it probably fell very far from the truth. So I think that winds up our time, Ronnie. Do you want to leave our listeners with one important thought today?
I'm so thankful for those that are listening who are involved in women's health care, because in this country, the health of women is not nearly as good as it could be. And I'm from the Southeast, and it's particularly not good in the Southeast. And I don't accept the fact that it needs to stay that way. I think we can do the women deserve to be healthier, and we as the providers of that health care are really an important part of that. We also need, help from health policy people, but I'm so thankful for the people that have been involved in women's health care, and please encourage people to join the mission and so we can get the health of women in this country better.
Well, thank you so much for that. I know that our match in OB-GYN has stayed strong, so we know that there's a passion and a purpose behind women's health care. So thank you guys for joining in with us today. I'm so happy to have had Dr. Alvarez with us. And this concludes this podcast session of Talking Women's Health. Join us next time. We look forward to seeing you in the future.